Welcome to this rapid-fire explainer on Behçet's disease. I am absolutely thrilled to guide you through this really fascinating condition today. We're going to take a pretty massive amount of clinical data and break it down in the absolute cleanest way possible. We want the graphics and words to move seamlessly through the whole explainer to help you build a perfect, rock-solid mental framework by the time we're done.
Let's kick things off with a bit of a clinical mystery. I want you to picture a patient walking into your clinic with severe, recurrent mouth sores. Now, how on earth does that eventually connect to them losing their vision a few years down the line, or to an angry red bump forming on their arm just from a tiny needle prick? It sounds like completely unrelated organ systems just going haywire, right? Well, as you'll see, they're actually all tied together by one unifying systemic issue.
All right, let's dive into Section 1, the profile. We're going to look at exactly who gets this condition and why.
So, epidemiologically, this is actually super interesting. Behçet's disease most commonly affects individuals right along the old Silk Road. If you look at a map, the highest prevalence literally stretches from the Mediterranean region all the way across to Eastern Asia, with really heavy concentrations in places like Turkey and Japan.
Zooming in on those populations, the peak incidence hits young adults, mostly right in that 20 to 40 age range. And a quick note here, while anyone can get it, it definitely tends to be more common and honestly a lot more severe in men.
Now, what's actually happening under the hood? At its core, Behçet's is a systemic autoimmune vasculitis. It strongly associates with the HLA-B51 gene. Basically, it looks like potential infectious agents, think herpes simplex virus or parvovirus, act as the match that lights the fire. They trigger this intense immune response where CD4-positive T cells proliferate and immune complexes get deposited, directly attacking the small arteries and venules.
Which brings us to Section 2, the presentation, where we'll cover the core clinical features. The almost universal presenting symptom, we're talking up to 100% of patients here, is recurrent, incredibly painful, deep oral ulcers. These are not your standard run-of-the-mill canker sores. They are deep, they show up in multiples, and they stubbornly hang around for 1 to 4 weeks.
And unfortunately, they usually don't come alone. In about 60 to 80% of patients, you'll also see recurrent genital ulcerations. They look a lot like the oral ones, mostly showing up on the vulva and scrotum. But here is a massive clinical pearl. Unlike the mouth sores, these genital ulcers uniquely heal, leaving visible scarring behind. Definitely something to look for on your exams.
Fast forward 2 to 3 years after those first ulcers pop up, and things can get much worse. Up to 80% of patients go on to develop severe bilateral ocular disease. We're talking uveitis, retinal vasculitis, serious eye inflammation that can profoundly impact vision. So it's such a wide spread of symptoms, how do we actually catch this? Let's move into Section 3, the diagnostic catch, looking at Behçet and a few more pearls.
This is where the pathergy test comes in, and honestly, it's incredibly simple. You just take a sterile 20-gauge needle, do a tiny 5mm prick on the patient's forearm, and then you just wait 48 hours. That's it. What are we looking for? Well, a positive result is super visual. You'll see an erythematous papule or pustule form exactly where that minor trauma happened. It perfectly highlights how hyperreactive their whole system is.
Now, to anchor all these moving parts in your memory for the wards, there is a fantastic mnemonic. Just remember the word pathergy. P is for a positive pathergy test. A is for aphthous oral ulcers. T is for thrombosis. H stands for hemoptysis. E is for eye lesions. R is for recurrent genital ulcers, and Y is for young at presentation. When it comes to the formal diagnosis, labs might just show generic stuff like a high ESR or CRP. To make the official call, you absolutely must have those recurrent oral ulcers at least 3 times in a year, paired with 2 other major symptoms. That could be the genital ulcers, eye lesions, or that positive pathergy test we just talked about.
And guys, here is a pearl you absolutely have to remember. This diagnosis is made primarily on clinical grounds. Unlike a lot of other autoimmune diseases where we rely on blood work, in Behçet's, autoantibodies are usually just completely absent. You really have to trust your clinical exam. All right, let's wrap up with Section 4, severe systemic complications and interventions. We need to zoom out and look at the whole body.
Because remember, this vasculopathy does not stop at the skin. It can cause deep vein thrombosis, fatal pulmonary artery aneurysms, non-erosive arthritis, severe GI bleeding, and even neuro-Behçet syndrome, attacking the central nervous system.
And that leads directly to this grim but crucial reality. Neuro-Behçets, the vascular aneurysms, and the GI bleeding are the main causes of mortality here. When you see these complications, they demand immediate, aggressive treatment to literally save the patient's life.
Because the disease is so widespread, our interventions are highly targeted. We hit the oral ulcers with topical glucocorticoids. For skin and joints, we use colchicine. For the really stubborn, resistant ulcers, we can use thalidomide, though you have to be super careful there since it's neurotoxic and teratogenic. And for those terrifying ocular and neuro complications, that's when we bring out the heavy hitters: systemic glucocorticoids and powerful immunosuppressants.
And there you have it. We hope that watching these graphics and words move dynamically through this whole explainer has helped you build the cleanest, most unforgettable framework for Behçet's disease. Thank you so much for listening to this explainer lecture brought to you by the Mid-Medicine channel. We've covered a ton of ground, so I'll leave you with this final thought. The next time a patient comes in complaining of a simple, frustrating mouth sore, will you just treat the symptom, or will you remember to look beneath the surface and check the health of their entire system?